Dr. Murthy, I'm going to put you on the spot just a little bit here, which is that aside from
Story of my life.
Okay, aside from cancer care or palliative, end-of-life palliative care, is there ever a reason for someone to be taking these drugs long-term? Short-term, I think there's agreement, 3 days after back surgery or whatever, but is there any legitimate reason why for people to be taking these opioid drugs long-term?
Well, so this is a good question because one of the big concerns that community members have around this whole campaign that we're engaged in to tackle the opiate epidemic is they worry that we're going to take opioids away from people who really need them. And the truth is that there are many people who have been on opioids for years for chronic pain and who feel that it is actually helping them. So having those conversations is challenging, but it's incredibly important. And so what we do know, though, if we look at the science and the data, is that the vast majority of people who have chronic pain do not need opioids. Now, let me be clear about what I mean by that. I'm not saying that opioids don't make them feel better, but what I'm saying is that the ultimate impact on their health tends to be more negative than positive. And why is that? Well, it's that number one, your body builds up tolerance to opioids very quickly, and you find that if you have somebody on opioids for weeks and months, you end up having to escalate the doses fairly quickly, especially in the beginning of treatment, because the body just gets used to it. The second issue is that you can actually paradoxically develop something called a hyperalgesic effect with opioids, which is that when you're on them for a while, they can actually sensitize you even more to pain. And the third thing for us to keep in mind is that opioids, they create a euphoria, they make people feel better, they treat pain, but all kinds of pain. Right? So some people will tell us that they find that the opioids not only help for their back pain, but they help to calm their anxiety, that they help in other ways. And so what we find is that we think we're doing something fairly benign and something that's helpful, which is giving someone a medication for their pain. But when we keep them on it for a long time, these negative effects tend to build up, and we actually put them at risk for addiction and also for overdose. Because keep in mind, the higher your dose, the greater your risk for an overdose. And the majority of deaths that we're seeing are not intentional deaths, where people are intentionally taking a large amount of opioids in hopes of passing out. These are unintentional overdoses, people who think they're taking a safe amount, but it's so high that it's actually hard to keep them safe. So this is why that's why this is a complex issue, because we have to be, I think, thoughtful about how we have this conversation with the community about the fact that opioids for chronic pain, with only a few exceptions, being cancer-related pain, end-of-life palliative care, that this is actually not the best treatment for chronic pain. On the flip side, there are other treatments for pain that we have to know about. So one is we know that physical therapy can actually be incredibly helpful and important for treating pain. We know that cognitive behavioral therapy can be useful. We know that we have a limited number of non-opioid medications that can treat pain, but they are effective. And we know that the more research we do, that we're starting to realize that there are other tools that could be investigated and could be potential assets as well when treating pain, like massage, like acupuncture and others. Now, if we really want to build out that toolbox so that we have a large set of non-opioid tools to treat pain, then we have to invest in research, in understanding more about what works and what doesn't work, in the R&D to actually develop new non-opioid medications that can treat pain. That's, again, why the investment piece is so important. So this is a complex issue, and this is actually why it's training doctors in how to prevent this epidemic is so important, but also so challenging.
So if those patients were your patients and they said to you, "Oh, doctor, it helps me so much. I know I've been on it for several years, but it helps my back pain. They're great. I want to stay on them." What would you tell them?
And this is it's not a hypothetical. I've had many patients like this. And the toughest ones, I'd say the toughest cases, are when a patient has been seeing another healthcare provider for years. And they come to you and they say, I fell, I was in a motor vehicle accident, I had a back injury 5 years ago, and my doctor in, let's say, New Hampshire has had me on oxycodone for the last 5 years. I just moved down to Boston, and I'm seeing you for the first time. Can you renew my prescription? And if you don't renew it, then a patient with the best of intentions might think, well, you're not providing good care. I had a good doctor there. Why aren't you providing good care? They might think you don't care about my pain. Why don't you care about the fact that I'm suffering? And so what I do, like in those situations, is one, I try to get a sense of the pain and their functional status. The reason I mention the functional status is what we have begun to realize more and more is that our goal in treating pain should not just be to get pain to zero, but in fact, even more importantly, it should be to improve someone's function. And that means, like, are they able to play with their kids the way they want to? Are they able to do their work? Are they able to walk around the house and just do that normal activities of daily living? So I try to get a sense of their functional status. The second is I try to get an understanding of whether they understand the risks and benefits of opioids. And I usually find most people know the benefits. Very few people actually know the risks. So that's the second thing I try and do. And the third thing I try to do is get a sense of whether there is evidence of a substance use disorder or addiction. Like, is the use of these opioid medications, in fact, compromising their life in some way? Are they spending a lot of time trying to get more opioid medications? Is it affecting their judgment or their relationships with family members? You can't do all of this in 15 minutes in a primary care visit, which is why part of what makes this challenging is that sometimes you have to have these conversations over multiple visits. And ultimately, what you have to do is, if you think there are signs of a substance use disorder, you have to get people into treatment. This is a challenge because we don't have enough specialists right now who provide medication-assisted treatment. But it's also challenging because we need to actually shift how we think about who provides medication-assisted treatment, which is that one of my beliefs is that treating substance use disorders should be part of the training that all clinicians get, not just addiction specialists. If you think about it, if you're a dermatologist, you were probably trained during a medical school and residency in how to adjust blood pressure medicines. If you were a neurologist, you were probably still trained in how to adjust someone's insulin for their diabetes. The question is why? Because we have understood that these are basic tools that are needed to treat illnesses that are very, very common, and so every doctor should be trained in those. I think what we're seeing with substance use disorders is that these are becoming so prevalent that it's important for us to ensure that all clinicians are trained in how to approach, diagnose, and treat substance use disorders, because it's hard enough to get someone to treatment. And we should have a no wrong door policy so that whichever provider you actually go to, it's somebody who can help understand whether you have a concern and get you the treatment you need.